end-of-life care is care that helps all those with advanced progressive incurable illness to live as well as possible until they die, enables the supportive and palliative care needs of both patient and family to be identified and met throughout the last phase of life and into bereavement. It includes management of pain and other symptoms and provisions of psychological, social, spiritual, and practical support. Life-threatening or life-limiting illnesses include the following: end organ failure, mental illness, dementia, post-stroke rabies, acquired immune deficiency syndrome or AIDS, cancer, chronic obstructive pulmonary disease COPD, rare diseases, malignant hyperthermia, serious physical injuries, post-acute myocardial infarct, blood dyscrasias, drug-resistant tuberculosis, congenital disorders, among others. Quality end-of-life care consists of a number of domains and treatment of particular conditions. This includes physical and emotional symptoms, advanced care planning, aggressive care near death, global quality of life, family burden, survival time, psychosocial well-being and functioning, spiritual well-being, patient perception of care, psychological and cognitive symptoms, social relationships and support, economic demands and caregiving needs, hopes and expectations, and spiritual and existential beliefs. Common ethical dilemmas of end-of-life care include withholding and withdrawing medical interventions, surrogate decision makers, disagreement between patient or family and medical teams, unique religious preferences at end of life, non-beneficial or futile medical interventions. In the Philippines, the National Policy on Palliative and Hospice Care states general guidelines. A. The Department of Health, through the Disease Prevention and Control Bureau, shall develop guidelines, policies, and standards that shall facilitate the implementation and institutionalization of palliative and hospice care in the country. Considering that palliative and hospice care cuts across all medical diagnosis, population groups, and diverse professions and sectors, the DOH shall ensure the involvement of all concerned stakeholders, both private and government, in all the plans and programs that will be developed. B. Palliative and hospice care shall cater to various age groups tailored to age-related health needs throughout the human life cycle. It must be integrated into the country's health system and shall be institutionalized at all levels of care, from primary to tertiary levels care, through the service delivery network. C. Palliative and hospice care requires a holistic and multidisciplinary approach, which includes but is not limited to physician care, nursing care, medications for pain management and control, medical supplies, medical equipment, counseling, surgery, chemotherapy, and radiation therapy. D. Primary level health facilities, such as rural health units, shall provide palliative and hospice care through a community home-based care approach. DOH shall provide guidelines for the CHBC approach in collaboration with existing non-government organizations, private institutions, and religious organizations already providing home-based care throughout the country. E. Secondary and tertiary level health facilities, such as hospitals, shall provide palliative care, which includes consultation services, inpatient palliative care units, or co-management models. Hospice care in hospitals shall provide to terminally ill patients. It shall provide access to support services and other healthcare professions. Here we have a diagram that translates ethical principles into tangible applications for end-of-life care. The principle of autonomy can be seen when a physician encourages dialogue about end-of-life care and use of advanced directives so that the autonomy can be preserved even if the patient's decision-making capacity is lost. The principle of beneficence can be seen when the physician should do what they believe is in the patient's best interest, but this action must not conflict with the patient's right to self-determination. The principle of non-maleficence can be seen when many physicians view participation in physician-assisted suicide as a violation of this principle. The principle of justice can be seen when physicians should advocate for treatment of their dying patients, which is just and without discrimination. Lastly, the principle of fidelity can be seen when physicians should be truthful to their dying patients regarding the diagnosis and prognosis and advocate for their dying patients' wishes even when those patients' decision-making capacity has been lost. Effective advanced care planning is important in providing good care at the end of life because it enhances a discussion of EOL issues between the patient, physician, and caregivers. Perhaps even more important, it provides the mechanism to honor the patient's wishes even at a time when the patient may lack decision-making capacity. Therefore, effective advanced care planning can promote patient autonomy. Clinical indications for discussion of EOL care. For urgent indications, imminent death, talking about wanting to die, inquiries about hospice or palliative care, recently hospitalized for severe progressive illness and severe suffering and poor prognosis. For routine indications, imminent death, talking about wanting to die, inquiries about hospice or palliative care, recently hospitalized for severe progressive illness and severe suffering or poor prognosis. Information most important to patients facing a life-threatening illness. Most, chances of survival and resultant health state. For moderate, it is the impact on family lives. For the least, it is the length of stay, probability of institutionalization, amount of pain, ICUs, ventilators, etc. There are three options for end-of-life care. First is curative or acute cure. Life-prolonging and acute care options focus on cure. Second is hospice care. It is provided by skilled healthcare providers and volunteers. Its goal is to help dying people have peace, comfort, and dignity. It is based on comfortable care without any intention of curing a patient. People who are terminally ill or declared as dying within 6 months are eligible. It is provided at person's own home or nursing home. Lastly is palliative care. It improves the quality of life of patient and of their families. Prevention and relief of suffering by means of early identification, an impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. It is carried out in an institution like a hospital with various advanced facilities. Recommendations for ethical care at the end of life include the following. Adhering to the dying patient's right to self-determination or autonomy is central to ethical care at the end of life. Advanced care planning through a living will and identification of a proxy decision maker could enable the patient's wishes to be upheld even when the patient's decision-making capacity has been lost. Conflict regarding end-of-life decisions can be avoided with effective advanced care planning, proper education, and good communication between the physician, patient, and caregivers. Medical futility may be best described as an intervention that will not enable the achievement of the attended goals. Therefore, futile intervention should be avoided in the care for dying patients. Withdrawing an initiated intervention has the same ethical significance as withholding an intervention that has not been initiated. The provision of artificial nutrition and hydration should be viewed as analogous to other medical interventions. Requests for physician-assisted suicide typically reflect an outcry for help, resulting from an unidentified problem. The physician is in a key role to identify the issue and address the underlying needs of the patient. Effective management of pain at the end of life is a critical role of the physician. The principle of double effect allows for aggressive pain management even at risk of hastening the dying process. Advanced directives. Nature and form of advanced directives. An advanced directive is a document by which a person makes provision for healthcare decisions in the event that, in the future, he or she becomes unable to make those decisions. It tells how decisions about treatment are made, it assigns who speaks for the patient, and what treatments the person would want or not want. Under the U.S. federal law, an advanced directive is defined as a written instruction such as living will or durable power of attorney for health care recognized under state law, whether statutory or as recognized by the courts of the state, relating to the provision of health care when the individual is incapacitated. Two main forms of advanced directives, living will and durable power of attorney for health care. Living will. A living will is the oldest type of healthcare advance directive. It is a signed, witnessed, or notarized document called a declaration or directive. Most declarations instruct an attending physician to withhold or withdraw medical interventions from its signer if he/she is in a terminal condition and is unable to make decisions about medical treatment. Since an attending physician who may be unfamiliar with the signer's wishes and values has the power and authority to carry out the signer's directive, certain terms contained in the document may be interpreted by the physician in a manner that was not intended by the signer. Family members and others who are unfamiliar with the signer's values and wishes have no legal standing to interpret the meaning of the directive. Durable power of attorney for health care is a signed, witnessed, or notarized document in which the signer designates an agent to make healthcare decisions if the signer is temporarily or permanently unable to make decisions. Unlike most living wills, the durable power of attorney for health care does not require that the signer have a terminal condition. An agent must be chosen with great care since the agent will have great power and authority to make decisions about whether healthcare will be provided, withheld, or withdrawn from the signer. Combination Advance Directives. A Combination Advance Directive is a signed, witnessed, or notarized document which contains specific written directions that are to be followed by a named agent. Since it is not possible to predict all circumstances that may be faced in the future or to cover all possible interventions, specific directions may severely limit the discretion and flexibility that the agent needs and may restrict the agent's authority in a way the signer did not intend. The specific written directions may not be altered by discussions between the signer and the agent. Any changes necessitate a new document to reflect nuances or changed directions. A last will and testament. A probate court oversees your last will after your death. It allows you to appoint a guardian for a minor and public knowledge after it is recorded. It does not avoid conservatorship, which is when a court appoints a representative to handle your finances. However, a conservatorship can be avoided with a durable power of attorney, which will allow you to appoint a person of preference to handle your finances in the event you become incapacitated. It dictates the way that your assets will be distributed and utilized following your death. Lastly, most other posthumous decisions are addressed. Under the U.S. Federal State Law on Advance Directives, individuals have the right to accept or refuse medical or surgical treatment and have an advance directive and/or appoint a healthcare agent. Does not require individuals to complete any form of advance directive and nor do state laws. It expressly forbids requiring an advance directive as a requisite for treatment. When individuals are incapacitated and unable to receive information due to a mental disorder or an incapacitating condition, or if they are unable to articulate whether or not they have an advance directive, the provider may give the information to the family or surrogate instead. However, the information must be given to the individual directly once he or she is no longer incapacitated.